So good morning, everyone. This is Larry Boris. I'm the Executive Director of the National Association of Worksite Health Centers, and I want to welcome you to our program here today. The program is based on pandemic primary care. What we're trying to do is to have a series of events that really help employers learn about what's going on in the industry, particularly as it relates to the COVID-19 crisis and how you can address this. We've had events earlier relating to telehealth and how you can expand that and some of the new directions that are taking and some of the legal and regulatory requirements. We've also talked about the COVID-19 impact on our health centers. We did a national survey of worksite health centers to find out what employers are doing. Next week, we have a program on HSAs, health savings accounts, and the impact of HSAs on worksite health centers and how the COVID-19 crisis has addressed that. And today I'm pleased to have two speakers joining us today from Crossover Health to talk about their approach and what they're doing relating to pandemic primary care. And I'd like to start it out by introducing Dan Lord, who's the Director of Clinical Programs for Crossover Health. So Dan, I'll turn the control over to you.
All right, well, thank you so much for having us, Larry. We've had a long relationship with NAWHC and appreciate you guys including us. I'd love to introduce my colleague here, Stephen Ezekwesili. He's the Chief Medical Officer of Crossover Health. He came to us from the VA system where he was Chief of Staff. And today he runs our medical group. And so we're excited to talk to you guys about our response to this pandemic and some of the changes that we had to make to our program in order to meet the needs of our clients. So I'm going to pass this straight over to Stephen.
Thank you, Dan, and thank you for having us here today. I appreciate the opportunity to talk to you about what we've done to address the primary care needs during the pandemic. So Crossover Health provides on-site and near-site healthcare to a number of activist employers, and these are people who are self-insured and are looking for an opportunity to look at ways to change the healthcare experience and to improve the primary care experience. We're also making our switch towards being a more digital-first program, so that there'll be greater opportunities for people to engage us starting in the digital or the online world before having to come into the physical world on an as-needed basis. So we want to talk about our response to COVID-19, some of the supportive care we provide, and how we're looking at preparing for the new normal, including how do we get back to campus. I prefer the term back to campus as opposed to the term return to work, because people have been working while they've been in self-isolation. So in terms of our response to COVID, as you can see, the number of cases has been increasing over the last 8 weeks or so, and we anticipate that we're going to see the pandemic continue to go on for many more months, and this is really something that is going to be with us until there's a vaccine or effective treatment. So in terms of what Crossover's immediate response was, when we first started hearing about the effects of the pandemic, we decided to start educating our providers on what was going on. And so we started with the creation of a clinical task force in January to monitor what was the response in other countries, what was going on with the CDC, and also be able to let our providers know what was happening. We ended up setting up a COVID command center in March, which allowed us to have a coordinated response between our communications, our clients, and our clinical task force, so that we were able to keep each part of our organization abreast of what was going on, as well as be able to develop communications with both our clients, our members, and our staff. And part of this was reflected in us doing a weekly and bi-weekly client communications to really let people know what was going on, how we were approaching the pandemic, and be able to answer any questions or concerns they might have. In terms of clinical response, one of the things that we did initially was create what we referred to as our national response level. And this really reflected where we saw ourselves in terms of our ability to provide care as an organization, with level 1 being the provision of care as business as usual, to level 6 being if we were so hard hit by the pandemic that we did not have staff to provide care, how would we approach things? And by being able to shift through these various levels, where it would move from primarily a physical approach to a more and more virtual approach, it allowed our staff and our clients to understand the triggers for us to make decisions, as well as when certain situations arose, how we would move and how we would manage. And I think this really helped both our clients and our members and providers feel much more comfortable about knowing what was going on and feeling prepared for things as they were happening. Part of what we wanted to do was prepare for the worst case scenario, and that would be that our staff themselves were dramatically affected by COVID-19, and that we would need to figure out ways to be able to consolidate our resources to be able to provide care in a regional as well as in a national approach. And as the pandemic came on board, we moved rapidly from recommending virtual care to requesting it, and then ultimately to requiring it. And then we also developed what we call the pandemic primary care framework to shape our responses and our interactions with members and clients. So in terms of the response levels, just as I was mentioning, the big changes were as we got to what we referred to as level 3, where we were starting to limit the amount of services that we're providing in a physical sense, and requesting or requiring patients be remote, and that most of our resources were now focused on online or virtual care. The big change between level 3 and level 4 is at level 3, we still have individual clinics serving individual clients, but by the time we got to level 4, our clinics were beginning to get pooled, so that we would have pooled physical spaces, and depending upon the state of resources, either offering pooled virtual resources as opposed to individualized virtual resources. And by individual virtualized resources, I mean that the ability to request a specific provider to address a specific condition, as opposed to in a pooled situation, having to use a common pooled resource like one primary care provider or a behavioral health provider to address needs. And as I said, the main issue was really that transition phase from level 3 to level 4, and level 3 to 4 being where we're moving from having the individual teams to the pooled teams, and level 5 being the situation where we have no physical presence at all and virtual is the only approach, and that again being a pooled approach where we've pooled our resources to be able to provide care across the nation. So we referred to the development or the pooling of the practice as the development of a super practice, and what that meant is that we started in the top left-hand corner today when we'd have individual clinics and individual clients, and that we would start to regionalize those resources as areas were affected by the pandemic, ultimately potentially resulting in 3 regional areas that would provide services to clients in that region. And if we were further affected, pulling things down to where we had what we referred to as a super practice, where we were marshaling resources from across the country to provide a limited form of care to all of our clients and all of our members. Thankfully, we have been able to remain in essentially what would be called between level 3 and level 4, where we're still able to provide individualized virtual care, although some of our care in terms of physical practice has been pooled. So as I'd mentioned at the very beginning, we had been looking to move towards being a digital first company, where we would want care to start in the online sphere, either in a virtual or a synchronous fashion. And this had been something we'd planned to do over the next 2 to 3 years. And the pandemic forced us to do all of this in about 3 weeks. And so as we take a look at the next slide, what it shows is that when the pandemic was starting to hit us, the beginning of March, we were doing very little virtual care. We had less than 200 appointments that were being done in a week in virtual care. It represented about less than 2%, about 1.8% of all our care was virtual. And by the time we got to 3 weeks into the pandemic, we were up to 86% of our care being virtual. and we've remained in the high 80s to the low 90s in terms of the percentage of our care that is virtual compared to that which is done in a physical environment. We like to say that we're not telemedicine. We're not a point solution dealing with just episodic urgent care. We really feel that what we've done is change our delivery model, but our care model is unchanged. We continue to provide a holistic approach of referred to as comprehensive primary care, really following the biopsychosocial model of care, because for us, primary care reflects having primary care teams, behavioral health, and physical medicine all working together to meet the needs of a population. And that when you're dealing with issues such as the pandemic, which affect many aspects of people's health and well-being, we're really needing to have a more holistic approach to be able to deal with what is essentially now becoming a chronic condition. And we shifted, as I said, to a more pandemic primary care framework, where we're really thinking about what are the impacts of COVID-19 on people's overall health and well-being, and how do we as a primary care facing organization address that? And part of that was a move to more proactive outreach of our population. So our pandemic primary care framework, we like to think of as summed up by the terms prevent, detect, treat, and cope. Prevent was really focusing on how do we make sure that we have maintained people's baseline health and well-being, and that they know that they're connected to us throughout this pandemic to be their source of care and their source of advice, and that we are able to reach them either in an asynchronous, such as secure messaging, or a synchronous fashion, either phone calling or virtual video visits, or if needed, in-person visits. And so while we want to focus on any acute issues they may have, as well as managing any chronic conditions, we also want to be involved with them in terms of being able to detect any possible infection, in terms of giving them advice on how to minimize the risk of becoming infected, decreasing the risk of spread, and then also playing a role in helping to detect infection through testing, and helping people understand what they need to do in terms of quarantining or isolating themselves, and the steps to take to be able to return safely back to the workplace or back to home, or to minimize the risk for others in their home. Now, while there are no treatments for COVID-19, we wanted to make sure that we were working closely with them to provide symptom relief for anyone who is infected, as well as dealing with any issues that might be exacerbated by infection or exacerbated by stress or issues that would occur as a result of COVID-19. And that really leads to the issue of coping, where we want to make sure that we're allowing members to understand that this is perfectly normal to feel stressed during this period of time, and these anxieties are to be expected, and to be able to be there as a source of support, both in terms of helping them understand what is going on with COVID-19, as well as providing them with resources to help them remain healthy. And this could run the gamut from behavioral health services to how do you actually make your home site an ergonomically safe site, so you're not incurring injuries or exacerbating conditions due to working in an unfamiliar work environment. And so part of our proactive member outreach, we focused on addressing those people who were most likely to have issues first. So we essentially created action lists that triaged people depending upon whether or not they were frequent users, had chronic conditions, were people who had ongoing medication needs, were known to have COVID symptoms. And our care teams would reach out to them either online, through messaging, through phone calls, and try to assess how they were doing. Did they have any particular needs? Did they have questions or concerns? If they were infected with COVID, we would enroll them in a COVID monitoring program where we would provide them with regular and frequent contact to make sure that they were recovering, and if they needed to be escalated to a higher level of care to assist with that, or to be able to provide them symptomatic relief. And if they had particular health needs, we would connect them either with a provider who would help address those needs, or if they were interested in trying to adapt or develop healthy behaviors, we were able to connect them to various different programs that they could engage with to help them with coping with being in an unfamiliar environment. So these things included things such as fitness programs or other lifestyle programs. And one of the things that we have introduced is a COVID vulnerability index. This is an AI-based predictive model, which based on various factors gleaned from the patient's electronic health record, allows us to determine what the potential risk would be to that individual if they were to be infected with COVID-19. And this allows us another way to be able to risk stratify patients, to identify those people who we could reach out to in a proactive way, as well as being a source of information to providers that when they are in contact with a patient, to be able to take into consideration the potential risk of infection that someone might have when discussing their overall health needs and whether or not they have signs or symptoms that are potentially related to COVID. I'm going to turn it over to Dan to talk about some of the supportive care programs that we have developed.
Thanks, Stephen. So, yeah, we wanted to also make sure that we're providing a robust amount of resources, education, and COVID-specific services to our clients to make sure that we were really serving them as best as possible. And so some of the things that we created are specific webinars and online fitness for members, as well as any of the clients that we're hoping to get involved. And really interestingly, we're seeing hundreds of people sign up for our fitness services, and it's body weight exercises you can do in your living room, and it's really cool to see the engagement with some of those services we can offer. We're also developing webinars specifically around the COVID issue, dealing with grief, new approaches to stress reduction, meditation, staying fit and sound at home. And these are all services, webinars provided by our care team, and really well attended. And we've put together a really nice landing page with all of our materials, all of our COVID resources. And going forward, we're going to continue these webinars and educational series for all of our members. Behavioral health, as Stephen mentioned, is one of the key ancillary services, along with primary care, that we're really making sure that it is accessible during this pandemic. There's a lot of stress and anxiety, as we know. Stephen also mentioned our digital first approach, and this is really important because the demand of mental health services has increased. It definitely hasn't decreased. And so we want to make sure that we're stratifying patients into the right risk categories, and we deliver the right tool at the right time. So when patients come in and log into Crossover, they're filling out, for mental health, they're filling out a triage tool that really shoots them down the right care pathway. And we can deliver the right level of services to more people the way that we do this. A lot of our care, of course, is delivered virtually because of the situation right now. Virtual visits really transfer over well with mental health, but it also allows us to leverage all sorts of other tools, like more frequent asynchronous messaging, digital tools like different apps for mindfulness, or different cognitive behavioral therapy apps. So we can really leverage digital tools when we're virtually differently than we can in person, and it's really helped us manage the demand for mental health. Also, as Stephen mentioned, there's ergonomics and all sorts of things. Musculoskeletal doesn't go away just because of the pandemic. And people are usually moving less now, which we already knew was an issue. And there's a lot of repetitive stress injuries, back injuries and neck injuries, that are probably underserved right now because people don't have access to their normal in-person care. So similar to behavioral health, we have this digital first front door that we can route people to the right level of treatment. People probably don't realize that we can deliver a robust musculoskeletal service just online. Some of the most important parts to musculoskeletal care is the diagnosis, and doing a really thorough history digitally is really effective for getting to the right diagnosis. And then, of course, we want to confirm that diagnosis with a video visit, and we watch somebody move and do some movement-based orthopedics to make sure that we're solving for the right problem. Of course, not everything can be solved online with musculoskeletal, so we use our care navigation services if somebody needs more specific orthopedics, imaging, or pain management, but they're hopefully being managed within our continuum here. And we can deliver all sorts of remote treatment that doesn't involve even just virtual visits. We're delivering robust home exercise programs. We're doing ergonomic audits to make sure people's desks, home workstations are set up now, exercise, and just different nudges to make sure people stay on the treatment plan. They have education resources and other things to make sure that we deal with the back pain and neck pain that still goes on. As part of that effort, to educate people about what physical therapists and chiropractors can do virtually, we put on a Show Me Your Injury event where somebody can jump on for 15 minutes and have a consult with a musculoskeletal expert, and they can talk about all the different services we have and how we can solve their problem and get them moving easier, audit their ergonomic setup, etc. And so this has been a really great service, and it's a great partnership tool with the primary care team to really have a robust, comprehensive service. So I'm going to toss it back to Stephen to talk about Back to Campus.
Thanks, Dan. So part of our goal is to help employers return to campus in a safe manner and prepare for what is going to be the new normal. And so part of what we've developed is a way to think about this is our Back to Campus framework, and how we see crossover fitting in with our clients to be able to help make this a safe and easy transition. Now, part of what we anticipate is that there's going to be some form of symptom screening that will occur, either symptom and temperature screening that will occur that will help at least risk stratify those people who are not or less likely to be infected and allow them to be able to enter into campus, but also identify those people who, if they fail a screen, need to undergo further evaluation. We can also help clients in terms of evaluating the risks of their various populations to identify those people who may be at higher risk for complications if they were to be infected, and to see if there can be accommodations made to allow those people to be able to return to work at a later date. Part of what we see as our role in the evaluation is doing things such as evaluating those people who have acute symptoms in a respiratory clinic, ideally an area that is outside of the main clinic or outside of the main campus, that would allow for people to be evaluated safely and make a determination of whether or not they should be returned home versus being allowed to return to work. And this would include diagnostic testing, ideally to be able to establish whether or not people are acutely infected, but also to include diagnostic testing when the period of infection is felt to have been resolved, to make sure that they are free of infection, are able to return to work safely and not pose a risk to their fellow employees. As serologic testing becomes better defined, we anticipate being able to offer this as well. While the overall percentage of the population currently is unlikely to be significantly immune, and we're still trying to determine what immunity will mean, we do anticipate that this will become a bigger issue that people will want to know more about in the future, because certainly, even though we can't be sure what immunity will mean, it seems likely that people who have been exposed and have developed antibodies will be at lower risk than people who have no antibodies. And so this may play a more important role in the future, and we want to make sure that we're well poised to be able to offer this service as well. And then again, part of the return to work is that we'll continue to address and treat those people who have both COVID symptoms, as well as treating the ongoing acute and chronic conditions which are not COVID related. And really, our overall goal is to make sure that there's an absence of symptoms and that people will be able to return to work safely. And part of what we've talked to our clients about is, just as they will be likely having a phased approach back into campus, that Crossover will also be deploying a phased approach to return back to campus. And so that when we return to campus and start to provide a service, we anticipate coming back in with about a third of our visits being physical and about 2/3 remaining virtual, and that we would try to trigger our return to campus with both the actions of the company, but also with what state, county, or local regulations are around social isolation. We anticipate most of the service that we're providing being focused primarily on acute symptoms, things that can't wait, but also starting to address some routine care, particularly for routine care that has been delayed, but is still somewhat time sensitive, be those certain types of immunizations or certain screening tests that need to be done. We would still be making sure that we screened all patients, and in the beginning, we anticipate patients having to call to make appointments. And it wouldn't be until we got to phase 2, which again, we would time with both what's developing with our clients, but as well as further opening up of social isolation guidelines by governmental agencies. And we anticipate this occurring when there's much more testing more widely available, as well as a greater availability of digital contact tracing, so that as we open up, if there are resurgences in an infection, that we have the capability to be able to identify those people who are infected and to be able to isolate them to minimize any potential spread. At that point, we would anticipate being allowed patients to be able to schedule online, and then we would be doing the full array of services, but we would still have a reduced physical presence, partly because we want to be able to maintain social distancing, but also because we anticipate that now that people have been exposed to virtual care and understand what it can do, that there'll be an increased demand for this. One of the caveats to our phased approach to opening up is that if there's a significant resurgence of infection, it is possible we may have to go back a phase or 2, depending upon the rate of spread and the rate of rise of infection. Phase 1, which would be essentially returning to the new normal, we anticipate would occur when there's a vaccine or significant herd immunity, where the risk of further spread of the disease is limited. And at this point, we would allow patients to be able to schedule online and in person. We would have all of our services available back in the health centers, but we would also be making sure that every physical option has a virtual option, because we want to give patients the opportunity to decide what is the right way for them to address and seek care. So in terms of how Crossover is helping our clients, we really want to be there to help them develop their back to campus plans, and we want to assist with any integration of any vendors they may have to make sure there's a comprehensive array of services that covers both the COVID and the non-COVID gamut. And we want to make sure that we're there and available to help with evaluation and testing of any and all members who would fail symptom screening. And this would include doing proactive outreach to those who are at risk for COVID-19 complications, as well as the monitoring and surveillance and the provision of supportive care to those people who test positive or who are suspected of having COVID-19. Part of this would be working with public health departments to make sure that contact tracing is occurring. And in cases where a community may not be able to do contact tracing on its own, we would step forward to help provide some of that support to our clients to ensure that appropriate contact tracing has occurred. Part of what we would also be providing is services to make sure that there's a clearance of any employee who's been out of work due to COVID-19, that they've been evaluated and found to be free of infection, and are able to be cleared for return to work. And again, we also want to make sure that we're providing comprehensive primary care to all patients, both for those who have COVID-19 and those without. So we think the new normal is really going to include a much larger focus on virtual care. We think that Crossover can be a critical enabler of population health, which will allow our employers to safely move back to campus and reopen the economy by supporting them through the Return to Campus program, and by making sure that we are playing an active role in surveilling the activity of infection and the overall health of their members. We anticipate that there'll continue to be significant noise, both from government and other entities, about the state of the pandemic and what the major issues of the day are. We feel that we are well poised to be able to help distill through those issues and to help members and companies formulate policy to help guide those companies into the very best practices. And we also believe that this shift to digital first is a meaningful shift, and it's going to last. That patients and clients now being exposed to virtual have had a much more rapid immersion in the potential of what virtual care will be, and that they will want to further explore this. going forward to figure out how they can use it to leverage care, not just for those members who happen to be at or near a near site or an on-site, but for those members who may be distant to the main company campus, that virtual actually allows an opportunity to be able to connect people over a much greater geographic region. We think that patients will not only expect this, but providers will also want to be part of this new virtual experience, and will expect this as a way to be able to make our healthcare delivery model much more efficient. Overall, our mission is to provide the very best care, not just COVID care, and we want to do this in a way that touches the maximum number of lives over the greatest geographic region. Thank you. Turn it over to Dan, and we're available to answer any questions that you might have about our response to COVID-19 and about Crossover's approach to care in general.
Thank you very much. Larry, I'll turn it over to you for questions. Oh, you're on mute, Larry.
Thanks very much, Stephen and Dan, for this great information. I know we have a lot of vendor partners who are really supporting employers, and it's important to share this information so we can all learn the best approaches. So what I'm going to do now is I'm going to go around the table. I'll be calling people by name as you're listed to see if you have any questions. And the first one we had was from Bill Updike. The question was, he was wondering if physical medicine team is tracking outcomes differently now than they were before. Yeah.
That's a great question, and the answer is no, because we deliver the same care model, and we want to measure that care model against previous care, because we want to be at the same quality, the same robustness, the same capacity, the same service level. So we measure it the same way. For example, in physical medicine, we use a tool called Photo to focus on therapeutic outcomes. It's a benchmarking tool that has a national database of physical therapy outcomes. And so that's the way that we benchmark our care, and that's the way we track our functional status of our patients as they improve, to make sure that they have the most efficient and effective care possible, and that doesn't change with virtual.
Great, thank you. Also, I had a question. Are you intending to do mass screenings for your clients, or is that an option you're providing? We had a survey of the NAWIC members and found only about 11% were doing mass screenings, and there was some concern also about staff safety and getting supplies and such at the centers themselves. How's Crossover addressing that?
So right now we're not doing mass screenings. We're really seeing that the majority of screening will occur with symptom screening and temperature screening, the combination of those two. And because of the limited availability of diagnostic testing, that screening those people who fail the symptom screening is probably the most effective way right now. As testing becomes more available and more accurate, then I think the possibility of mass testing is more realistic, and is something that we would be willing to entertain if that's something that a client wanted to do it. But certainly there are the logistics of how you would test thousands of people in a short period of time, and also working through the thought process in terms of how you're going to use screening in terms of a return to work or an ongoing surveillance, because certainly if you test, that it gives you information on a point in time, and we anticipate that if you're going to embark upon mass testing, it should be part of a longer ongoing strategy to monitor and surveil the overall population.
Great, thank you. Also, there was a question about the cost of antibody testing. Is that a concern of yours? I think I heard there was 100 different tests, maybe 13 that have been approved, maybe 3 that have been found to be truly effective. What's your perspective on antibody testing and the cost to employers for trying to adopt this?
Yes, I think that it's something that it sounds nice in the sense that if you knew people were immune, that you might have some greater comfort in being able to return them to work. Right now, I mean, the challenges are, one, we don't know what level of antibodies would confer immunity. How much does immunity really mean in terms of how long it will last, and will it really reduce your risk for subsequent infection? We suspect it will. We just don't know for how long. But the bigger issue is that because we've done such a great job with social distancing, it's probably only about 1% of the population that's actually been infected that you would consider to be likely to be immune. And maybe if you're a bit more aggressive in saying that more people have had asymptomatic infection, maybe it's 3% of the population. But even if you were to test your whole population, assuming that your population is reflective of the larger community, you're talking about maybe 3% of your workforce potentially having immunity. And that doesn't seem like that is likely to be a significant proportion of the workforce that's going to make a difference in your approach to return to work.
Okay.
The other issue is that not all of these tests have great sensitivity and specificity ratings. And so the specificity is particularly important because it's what tells you if someone is truly negative. And so if you have even 99% specificity, that 1% of people who will end up being a false positive, because so much of the population does not have has not been exposed or not been affected, at 99% specificity, at a 1% prevalence of infection in the population, essentially 1 out of every 2 positive tests is probably a false positive, and at 3%, it's 1 in 4. So, you know, the confidence you can have in a positive test may not be as great as one would like. Now, there are some newer tests which are coming out which have like 99.8% specificity, and that would reduce the number of people who are likely to be false positives, and that would be helpful. But I think really it's going to be when people are vaccinated or if there's been greater degrees of infection, that immunity testing will have a larger role to play and will be more impactful to a particular client or particular population.
Great, thank you, Stephen. We had a question from Brita Ryerson. How have your volumes been impacted during the transition of care and over time?
So overall, we have seen that we've seen actually a steady increase in the amount of care that's being delivered online, but we have seen a decrease of about 40 to 60% depending upon discipline. So services like behavioral health have maintained a much higher sort of 60, 70% rate of utilization. Primary care has varied between about 30 to 45%. And physical medicine is in about the same ballpark. One of the things that we've actually found is interesting is that by switching to a virtual first approach, we actually simplified some of our offerings. So things like preventive health exams, which might have been an hour, we've shrunk down to a half-hour appointment because we're not doing the physical component. And part of what makes our numbers look a little bit less is that we actually increased our overall capacity by about 15%. But overall, volumes are down between anywhere from about 30 to 45%.
Brita, do you have any follow-up questions from that?
We have seen very similar changes in our practice. And have you measured the impact of the outreach that you've been having with the high-risk patients? Have those outreach interactions resulted in more visits or utilization?
So we've actually seen about a 30 to 40% increase in secure messaging between providers and patients. And for the most part, it hasn't resulted in a dramatic increase in the numbers of visits, because I think people have felt the main feedback we've got is that people are very happy that we've reached out to them and that we've been in contact with them. It has allowed us to address some issues proactively, but for the most part, it's been more about making that connection and that people being able to address things like getting their medications refilled, but not necessarily that much around care.
Yeah, benefit.
One of the things we've actually found quite interesting, which is actually quite surprising to us, is our Net Promoter Score has actually gone up during the pandemic, and we've always had pretty high Net Promoter Scores in the mid to high 80s, but we're now in the 90s, and I think part of that may just be reflective of the fact that given how much restriction there is on healthcare in general, that people are just feel very grateful to be able to, know they've got a stable, constant, trusted source of care.
Fantastic. Thank you.
So at this time, I'm going to go around the table and see if there's other kinds of questions. So I'm just going to use the name that's showing up on your on the participant list. So Ray Tuck, do you have questions or comments? Great. Sure, you're not muted. Okay. All right. Ahun, I'm sorry, that's all I have shown here. Do you have a comment or question? Take yourself on off mute. Okay. Shadi Katira. Shadi, do you have a question?
I do not have any questions. Thank you.
Wait. Okay. S. Erickson, do you have any a question for us or comment? Just take yourself off mute. Okay. Bill Updike. Bill, do you have any comments or questions?
I actually do have a question, Larry. Thanks for asking again. I'm just wondering if, what you hear from clients and about the future of on-site work. And after all this settles out, who knows when that might be, what's the feeling? And obviously it's going to depend on industry and being located in Silicon Valley. There's a lot more remote here than there's going to be in manufacturing and all that. But is there a lot of discussion about the return to work being a certain percentage less than what it was before? Whatever it was before, the number of people coming into a job, my expectation is it would be less coming back because they're either sick of it or maybe they're getting more used to it. But I'm just wondering, have you heard much on that topic?
So we have had some feedback from some of our clients, and then also nationally, Twitter announced that anyone whose job is amenable to working remote will have the option of working remote indefinitely. And so some of our clients are talking about the fact that they don't expect to have the majority of people back on campus until 2021, and that there will be a portion of those people who will be virtual in an ongoing fashion. So we anticipate that there won't be the same density on campus as there has been in the past. And part of this is consistent with the way that we're seeing things as well, is that we anticipate that, people are now that, people have been working virtually, and a number of the companies have found that productivity has been just as good, that there won't be that pressure. I mean, the New York Times was talking about how some of the major banks are talking about reducing their footprints in New York City. And we anticipate that this will be something that will occur across the country. But that's also consistent with what has been our long-term approach to care, which is we want to really move to being a digital-first company where people start their care online, and then, if appropriate, continue online, either through asynchronous care such as secure messaging or synchronous virtual care, to be able to complete their healthcare issue. If they need to be seen, that can be done either because it's needed to be able to deliver the care, or if that's the patient's preference. But we anticipate that there'll be a larger and larger segment of people who will view virtual as a much more convenient and better option for them to be able to get care. And so we anticipate that, yes, the campuses will shrink, and that may also result in a change in how we staff and look at our on-site and near-site offerings.
Thank you for that. That was my point, was what will this mean for the on-site clinic business, and how will that look? Because I think that's a larger question that a lot of people will need to weigh in on. It'd be interesting to hear as this moves forward, what people think about it. Thank you for your answer.
Thank you. I had a question about the temperature taking to screen people on site. What's your perspective on that? Do you think that is useful for employers and centers?
So I think my personal preference is I think it's useful just because it's an objective measure, and that there are going to be some people who are going to be asymptomatic and not be aware that they're running a temperature. And by running a temperature, I think it probably should be something a little bit, measuring people who are a little bit lower than 100.4, because if they have a frank fever, hopefully they're knowledgeable about that. If they're not, at least it gives them an opportunity to be able to catch that and potentially intervene. The other is that there are some people who will minimize their symptoms. I think the culture in this country has largely been that you come to work unless you're near death, and even then you remote in. So I think that we have a expectation in the past, which has been that people come into work, and even though I think the pandemic may have shifted that framework for a lot of people, I don't think that will be universally true. And then the risks of people coming to work when they feel a bit under the weather is much higher now, and that being able to do something beyond self-certification is probably prudent.
Thank you. I'd like to ask again around table, Christine Haase. Christine, do you have a question for them?
Hi, yes, thank you. I actually just typed my question in the chat, but I had a question regarding your virtual preventive medicine visits. Are you deploying home test kits for biometrics in similar labs, or are you sending them out to local labs and regrouping virtually? How are you handling that workflow?
Yeah, so right now we're not sending out home test kits. We're looking at that as an option in the future, but we are utilizing local labs as well as our on-site and near-site clinics to be able to collect biometric data if needed.
Okay, thank you.
G. Hodge, do you have a question?
No, I actually don't. Thank you for asking, though. I appreciate it.
Okay. Well, I don't see any other questions, and others, if you're interested, please comment at this time. Otherwise, I do want to thank Daniel and Stephen for taking the time out to share their experiences and knowledge with us. And we're looking forward to having you join us for our future meeting, as I said, next one on May 20th, regarding health savings accounts and their impact on worksite health centers. Please go to our website at www.nawhc.org to stay on top of our programs and activities, and we look forward to seeing you in the future. So thank you all, be safe, and have a good week. Bye-bye.
Thank you.
Thank you.
Thank you, Larry.
Thank you, Larry.
Thank you.